Very much for taking the time. It's so hard to get the time, isn't it? And to give yourself the time to come here today with all the other demands. So I thank you for that. And thank you to Citywide. You know, I was just thinking when I was coming in this morning on the Lewis, you know, you're so always on the pulse. Citywide is just a fabulous organisation. And Anna, I know, I've been working with you for years, since the days of the National Advisory Committee on Drugs, before it was drugs and alcohol even, and just your fingers being on the pulse, and you heard what services were saying, and you reacted, and thank you for inviting my team and I to do this research. And then finally, thank you to all of the Research Advisory Committee members are here around the different parts of the tables, and thank you to the people who contributed. But I think, you know, like building on what you know, you were saying there, it's about people, and like the research is the research. It just gives us the evidence to be able to argue for what we need, all right? So the research, you know, it's facts and figures and numbers. But when you have those numbers, they can't be denied. They can't say, oh, that's anecdotal. No. The numbers give you the evidence. So that's why I like numbers, because then I can stand behind them and then say, look, there's the number. What are you going to do about it? And this is my recommendation of what you should be doing about it, based on the, you know, the research we've done. So this is a group effort. This team, there's Dave McDonagh there, Dr. Dave. There's Sonam here. There is Sadie isn't here. Jessica, our librarian, is over there. Philip is a mental health nurse, keeps me straight, and I'm Catherine. So thanks to everybody. So how do I work this? Let you roll it forward or backwards? Down. Yeah, okay. I'll let you. Why don't we just press the arrow? That's it. No. Okay, so what was the objectives? So just go through those for you. Let you work that for me, just check it for me. Thanks. So when Anna and Ruth approached me, they were saying, you know, well, what should we, you know, what do we do? You know we need to do something. And then I remember I was saying to you, well, let's start at the beginning. What's the size of the problem? Because if you know the scale of the problem, then, you know, you can argue for that. And then let's hear from local people who are dealing with this to what they need. So first of all, it's what's the scale of the problem? So that's like, what does the literature say about the prevalence internationally, and what are the risk and protective factors? And then what is it within Ireland? And then, well, what are services saying they need? Because you're the experts. So if I can get the numbers, and then you, the experts behind me, we can push that forward to move the whole thing on. So that's what we set about doing. So we used what we call a mixed method study. So we did a quantitative questionnaire, and we did sort of interviews with service providers. And we also did some online, open to the general population. And before we all did all of that, we actually did a huge literature review. Said, well, what's it like globally? What are the numbers? How can we stand behind these? So that's called a systematic literature review, which I learned how to do from Jessica, teaching us all in Trinity College how to do this. She's the expert. So this is what we looked at. So what we were looking at were the population of people who are using substances. All right, so that's our population. That's who we're interested in. And then we were saying, oh, what is the prevalence of ADHD amongst that population? All right. Now that's different question to if you have ADHD, are you using substances? All right, because the question was driven by Citywide and your services. So the population are the people that are using substances. And it's funny, even when we were starting this research, I don't know if you remember, I said to you, I'm reading all these papers, and do you know that the tone even of the papers about people who are using substances and might or might not have ADHD was different to the tone of the papers about people with ADHD who then go on to use substances? You know, there was that little stigma in the tone of even the papers. I was taken aback actually by that. So anyway, that's what we were looking at. And this is the approach that you're supposed to use. You go through all of these databases, you look at all the international literature, you say, this is exactly what I want, and then you sort of find those papers and you read them, and then you get somebody else to read them. So I've done a lot of reading, but that's what professors are supposed to do. That's my job. That's what my job. You know, I remember when I got a job out in Maynooth, he said to me, now, we'd want you to be reading. I said, oh, yes, please, let me read. I'm happy to read. But that's what you're supposed to do as a professor, and then take that learning so that you don't have to do the reading. That's my job. And then summarise it back to you. That's my job. Anyway, so that's where we did the reading, and we looked at the numbers. So we looked at over nearly 57,000 people in all of these studies, and we looked to see had they a diagnosis or had been screened for ADHD. So we were, you know, it wasn't just I think I have it. They either had a diagnosis or they were screened. It's working now, is it?
Scroll it down.
Roll it down. Let's try that. There it is. So when we did that, what sort of numbers did we get? So we got, through these 57,000 people, about 21% of people who are using substances, a range of different substances, have ADHD. So that's 1 in 5. So if you're running a service for people who use substances, at least 1 in 5 people coming in your door have ADHD. That's a lot of people. Could be even higher, depending on the substance, as you'll see in a minute. Let's just put that number, because what does that number mean? That's 21%. In the general population, it's only 5%. So it's 4 times higher. ADHD is 4 times higher than what it is amongst the general population. 4 times higher amongst people who are using drugs and alcohol. So this is obviously a challenge. So nobody has looked at, in the literature, I noticed very few people had actually gone to the trouble of saying, well, what is this by gender and different drug types? So although the literature, you know, we worked out this 21%, I then did further study on the papers. And I said, well, let's pull out the different drugs and the different genders, and let's look at that. And that's where we got the next set of results. Oops. Go there. This modern technology, there it is. No, I have to go back to this. This is the key side. So amongst women using benzodiazepines, it's nearly 40%. It's 2 in 5. So when the women coming in the door who are using benzodiazepines, 2 out of 5 of them are actually have ADHD. All right? And generally, you know, with the males, maybe 1 out of 3 using benzodiazepines. Amongst the opiates overall, 1 in 5. Over alcohol, 1 in 5. But this was actually the highest. The benzodiazepines was the highest. So people coming in who have a challenge with benzodiazepines, but 2 out of 5, 40%, 2 out of 5 of those women will have ADHD or ADHD symptoms. So that has not been done before. None of the 162 papers out of the 1,000 papers we actually searched through gave that level of detail of results. None of them. So when I pooled them all together, we were able to actually do that. So that is brand new research that has never been published before. Actually, what is it by drugs? So we know it's around 21% overall amongst people who use drugs, but actually look at how women who are using benzodiazepines, it's not 1 in 5, it's 2 in 5 for them. Right. So that's new. So once we'd done that, then we said, okay, that's the international literature. Let's go and look at what's happening here in Ireland. So now I'll have to say it wasn't a random survey, all right? It was an online survey. Anybody could answer the survey. So we had this survey. We got 288, I think, in total answered it. And let's look at what did we find there. And we actually asked a lot of questions, and the details are in the report. But let's just give you the numbers there. And then we also did the interviews with people as well. So, Dave, do you want to take that over and say a little bit about that?
Yeah. Sorry, Catherine, just before you go, Dave.
Thank you, Catherine. So just quickly to go through some of the top line results. Obviously, the report is an awful lot more detailed, just to give you some ideas. So we had 534 people actually consented, but only 268 people actually fill in the online survey. And then we also collected 20 written surveys. So we had a peer working on the ground, and they managed to actually visit people who were possibly within the homeless community or in Merchants Quay. So we actually also got a number of questionnaires, paper questionnaires completed. So the average age was 42. and this ages was from 18 to 80. So it was quite a large range of ages spread. The predominant gender was female, so we had 171 females, but we also had 4 other people who didn't recognize their birth gender as either male or female. But we did ask them about their sexual orientation, and very interestingly, we had about 28% of people who said they were not heterosexual, which was quite interesting. So we have, let's get this. The other thing I just want to point out here, this wasn't really a normal sample, as Catherine mentioned. It was an online survey. 72.6% had a 3rd level education, which is much higher than what we would call the normal number of people in Ireland with higher education. I think that's around 63%, the CSO figure, so it was much higher, and that actually surprised us. So it wouldn't be what we would call a standard population that would be in drug treatment services. We did have about 84 people who had attended or were attending some form of drug treatment service. And so what we did is we broke down our data into those attending or have attended a drug treatment service and those who hadn't. And then we looked at ADHD and autism spectrum disorder. So you can see here this number here, but of the people who had attended drug treatment services, 21.4% had a diagnosis of ADHD. And then when we asked the people who hadn't got a diagnosis to fill in a questionnaire, the ASR is 6, 32 people screened positive for ADHD symptoms and met the threshold for a diagnosis of ADHD according to that screening tool. And that was 49.2%. So that was actually very high. So we did the same thing for the people who had never been in a drug treatment service, and we found that, again, 22.1% had a diagnosis of ADHD, and when we asked for those who hadn't got a diagnosis filled in the screening, we found that 51 people, or 34.2%, screened positive using that instrument. So when we combined those figures in total, just to look at people who are at risk of ADHD, we found a prevalence rate, potential prevalence rate within that population of 51%, 146 people, which was actually very high. Interestingly, the 2 percentages of the diagnosis correspond with the numbers that we actually found in our systemized review that Catherine talked about a little bit earlier. And when we went on then to autism, we used the autism spectrum quotient instrument. 11 people out of the 84 had a diagnosis of autism, and then 19 more screened positive when we use that instrument. For those never been in treatment, 30 people had a diagnosis of ASD, autism, and 47 people, 29% screened positive. You can see how many more people screen positive. Now it is a screening tool and would have required a clinical diagnosis. However, again, when we combine those numbers, we found that about 37% of the people could have are at risk of having ASD. Then we combined all of the numbers between both conditions, and that told us that about 31% of the people who had attended a drug treatment service were at risk of having both autism and ADHD, and about 51 people, or 25%, who had never attended a drug treatment service are at risk of having both conditions as well. So that was the way that the numbers came out for us. Sorry. Sorry, it's going. Oh yeah. Excuse me. So just looking at some substances, cannabis was a substance by far the highest prevalence, or I say illicit prevalence. Obviously, alcohol was, but when we look at illicit drugs, with a lifetime prevalence rate of 78%. So that means 78% of the people had used cannabis at some stage in their lifetime. And then when we looked at cannabis, we found that there was a significant relationship between those who were using cannabis at least weekly and ADHD. And that was, for anybody, the p-value, probability value, was actually very low at 0.003. We also reported that 54% of people who had a diagnosis of ADHD reported to be on medication for that condition. 23.2% of the people diagnosed with ADHD have or had attended some drug treatment service in the past, which I mentioned a little bit earlier. And 17.6% of people diagnosed with autism spectrum disorder had or have attended a drug treatment service at some stage. What we did interestingly find, that we found a significant relationship between those who screened positive for ADHD and who had ever attended a drug treatment service. And that was kind of an interesting finding. Sorry. It is awkward, yeah. It is. It's not, again, what I just wanted to put that one at the top. We did not find any statistical difference between males and females on autism or on ADHD. And that's interesting because a lot of the literature says that males have higher levels of ADHD, but we didn't find that in this population. And you did see that we had a higher proportion of females within the, and that's an interesting point that maybe we need to look in a little bit further. We found a statistical difference between heterosexual and the LGBTIQ groups and ADHD. So that group, the LGBT group, had higher proportions of potential proportions or risk of ADHD and autism than the heterosexual community. You can see 64% as opposed to 51%, and we had 57% for ASD, and we found that actually a very surprising, interesting result, and it was again statistically significant. We also found very statistically significant association between people dependent and not dependent on alcohol or drugs. One of the questions we did ask, we asked people, do you believe you're dependent on alcohol or drugs? And those who said yes, we looked at that and the people who didn't say they were dependent on ADHD, and we did find a very strong, significant association. Cannabis, as I mentioned, was the most frequently used illicit drug, at least weekly, by 28% of the population of the sample from our study. And we did find a statistically significant association between people using cannabis at least weekly with and without ADHD. In other words, people with ADHD were using cannabis more often than people who did not have ADHD. And I just put in that last quote there because we did get a number of quotes from people who told us why. Cannabis is one of the few things I have found that makes my brain quiet. So self-medication, and that's something that came through quite strongly as well from the discussions with the services when I went to visit them. Sorry, Phil. The other way, is it? Yeah. We collected all the data from, with 21 people participated in the qualitative part, the interview part. And we analysed it all, what we call using thematic analysis. So I don't expect to explain all of that, but we broke down everything into themes to understand what was the central and common things that people were telling us during these interviews. So 10 different services. So we had a good spread of services right across the city and one of the services in rural part of Ireland as well. So these, we haven't got time to go through a lot of this, so just a few of the little points. It was found that the majority of service providers did not have any formal education in or training in neurodiversity. And that was, I think just one service, Alison service, I found that they had formal training, but most of the services didn't. And even the term neurodiversity was new to many, many people. Yes, they had heard of autism and ADHD, but neurodiversity as a term. We don't have any specific training. It's more in-house training and awareness. So a lot of the training was kind of done trial and error on the ground, working with people. As many people said to me, we work with whoever walks in the door. We deal with whoever walks in the door. And that's how people learn on the job. The whole training issue is a really big issue. because it needs to be maybe systemized, standardized, and everybody works off the same hymn sheet. And I think that was something that was coming through from what people were telling us. Managing the needs of people who attend the services has been learned on the job using the trial and error approach. And that's the way many people spoke about. And here's an interesting comment, is to try and recognize the difference between a disability or any kind of deep trauma and someone presenting it, who's on the spectrum. It's learning on the job. It's kind of working through the issues that the person has and then learning from those issues and how to deal with them. So the lack of referral pathway, that came through almost from everybody. There isn't a referral pathway. Here's a comment that he got childhood ADHD and understood, medicated, but he couldn't get an adult expert. And that is a problem for maybe our national services, because obviously the client here commented that children are ages 7, they're not self-medicating, but adults are. So there's a real harm to people. Just one other comment that I thought through is a lady told me about her son who had been through to SASI, got a diagnosis took about a year, but once that child hit 18, the service support ended. The national support that the lady was receiving for her son ended, and then she was forced then to go down through the paid for route, which can be very expensive. No, got absolutely nothing. Was commenting that was quite. I don't think there's a clear pathway, and the GP. Here's an interesting story that somebody told me, where a client in her desperation sent the person to a GP, but the GP turned her away and said, well, it's not, you don't come to me, but where do I go? And even the GP was reluctant to actually provide any further information. Providing appropriate support for those with mental health and drug and alcohol problems was raised by more than a few people, by a lot of the providers, and it's a major issue for services, trying to deal with it, trying to work with somebody who has a lot of serious mental health issues, and there's just nowhere to refer them. And people just said, I have no place to go with these people, what do I do? And that was something that came through loud and clear. Back to Catherine.
What I think was really interesting as well was that, as I say, from the research, was the fact that we did pick up the differences between the different types of drugs that people are using, different genders, but actually also there's nothing, where is yourself? There's nothing in the literature about LGBTQ plus people. And the rate in our survey, now it wasn't a random survey, but even within that, the rate was much higher within that population. So I think that's new as well, and again, something that people are not talking about. So I think that's important. And then we heard from yourselves and what you said you need. So what do we do with that? So I've written up sort of a 5, thanks to Sonam, put these together in a very nice brochure here on a policy brief. Sonam did that for us, so thank you, Sonam. 5 key recommendations. I could go through them in detail here, but actually they summarize into 2, but I'll summarize them in a minute. So first of all, a gender, sexuality and drug of choice lensed ADHD awareness. So not just awareness, but actually a gender, a sexuality and drug of choice lens also needs to be brought to that as well. Communication, non-stigmatizing. Lynn, you said about blame. And that it just hit me when you said that. I said, I was talking this morning earlier on, and a teacher contacted me, and I was just thinking of how many children have been blamed in school for not sitting down, getting labelled as the bold child, getting labelled as the child who doesn't know anything, who can't learn. It just breaks my heart to hear that. And you brought up that blame. We need that non-stigmatizing, building on that child or that adult's strengths. The strengths-based approach. I mean, I've done other research, and it's the strengths-based approach. Like, you build on that person's strengths, not on their weaknesses. And that, I think, is non-stigmatizing, strengths-based approach is a very important aspect of service provision, which you do, you know this. This idea, I think, is important, number 3, really bringing all of that into number 3. existing training, expanding that, you know, like the training, say, that you have all received, or again, even are the teachers and the services, the health and social services, to actually bring in training. And that has to be sustainable, because, you know, I was talking to you about this morning. You know, we can bring somebody in. We'll bring somebody in and they'll give us a talk. Well, if you're not in that day, you miss the talk. Now, I know we're recording today. But, you know, what about next month? Are the new staff next week? So really some sort of sustainability in training, you know, that it needs to be actually as a fundamental within the professions, the training. But in the meantime, to kick things started, you know, I was saying something like an online, free online, you know, training. They're called MOOCs, Massive Open Online Courses, that anybody can access, you know, can be developed at a very, very reasonable cost. So that's something that maybe you could advocate through your services for the National Drug Strategy to do as step one. Because, you know, if we're going to wait for the ideal, we'll be waiting. Meanwhile, you are the people who are in the services that need, what am I going to do? Where am I going to learn? Where am I going to get the skills? How can I share best practice? How can I find out what they're doing and what they're doing of the best practice says we should be doing? So some sort of a very, you know, short, simple online course will get us started, and it can take those sort of anti-stigma, strengths-based approaches, and your voices carries through the research into some sort of a training module to get us started. Integrated care, I mean, that came through there, what you were saying, Dave, in terms of service providers and parents, you know, and people saying, well, where do I go? And, you know, if I'm in the children's services, where do I go when my young son or daughter is 18? So that sort of integrated care aspect. And then finally, again, we have our mental, so we have all the expertise on the team here, which is great, and then they tell me and then I get to tell you. There's a thing called the International Consensus Statements. So these were statements that were developed over a period of time by international mental health nurses, psychiatrists, social care, a whole group of international. And they have provided these consensus statements. So they have agreed, they have reached consensus on these statements about how to treat people who have both substance use and ADHD. And they are saying, you know, we live in a real world. I mean, ideally, you would like somebody to be drug-free. We live in a real world. That is too high a bar to expect. So they're saying to be able to give a quality diagnosis, you go back and you say, how was that adult or that person before they were 12? And you speak to the person, you speak to maybe the parent, friends, relatives, teacher, and you find out, you know, where are the symptoms there before 12. And then you say, well, did you have any periods of sobriety or when you were using less, you know, substances, and how were your symptoms then? And through that, a diagnosis can be made. Now, this is not Catherine, all right? I'm not a medical professional. I've just done the research and done the reading. And as I say, Philip here is a mental health nurse with many years' experience, and I've checked it with Philip as well. And then they're saying, well, what about treatment? You know, can you give somebody treatment? And the answer is yes, you can. You can, because the consensus statements say yes, you can treat ADHD and substance use at the same time. So as I say, that is coming from these international consensus statements. So we need to get them out there and into practice. So overall, I would say we have two recommendations. One, let's not wait until we have the integrated care pathways and we have the blah, 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 blah. Let's push for immediate training that, you know, so that you can deal with what's coming in the door next week, or, you know, it'll take a little while to get the training, but it won't take that long, a few months. And meanwhile, be working on, you know, the bigger picture. And the second recommendation is, let's make sure these consensus statements are, you know, disseminated and implemented and shared so that people know what is best practice. So if we keep it simple, those are the two key messages. And we can defend those two key messages because we have the numbers, all right? So you did see a lot of numbers, but just go back to the very basic 20%, 21% of people who are using substances have, you know, are at risk or have ADHD. It's only 5% in the general population, all right? So it's 4 times higher. So let's put 4 times the effort in. You know, we deserve 4 times the effort. It's as simple as that. Okay, nice little simple number. And then here's our 2 recommendations. So that's us. So thank you for listening.